Good afternoon. Thank you very much. So I'm going to be talking about the pitfalls of point-of-care ultrasound. So I have no relevant disclosures, but I just wanted to mention, Dr. D mentioned he has one device charging up in his hotel room. I have 5 devices. So this is a field where bigger is not better. It's more is better. So smaller is the way we want to go, and the more the better. In terms of our In terms of our objectives, we will be talking today about the new role of cardiac ultrasound in medical education, some common errors in clinical practice of cardiac POCUS, as well as the current challenges facing POCUS and the impact on us, on the Echo Lab. So I wanted to introduce the Canadian Society of Echo POCUS Committee. We're quite an active committee within the CSC world, and we just recently published a paper looking at the state of the art in medical school education for cardiac POCUS. And what we did was we looked at how cardiac ultrasound is being implemented at a number of schools across North America, so both US and Canada. And after doing that survey, we were able to put together a model that sort of takes the best of all the medical schools. What we noticed was that some schools are using cardiac POCUS to teach anatomy in year 1, because you're seeing the movement of structures. It really helps them learn better than just comparing to plasticized specimens. The other thing is in year 2, for example, when they're talking about physiology and they're going through hemodynamics, they can actually see the impact of some of these hemodynamics in disease states such as pericardial effusion, and how that's actually affecting the chamber pressure in a visual manner to understand hemodynamics better. In year 2 and 3, when some students are entering their disease block, they're learning about diseases like amyloid and the histology behind that. But they can also learn about the impact on the patient in a very visual manner that drives home the impact of this disease. And they can picture how different organ systems are affected, in this case, the heart. And then finally, one of the most important uses of cardiac ultrasound is how it could enhance the physical examination. So you all have those medical students that just could not hear heart sounds. No matter how hard you tried, they just can't hear it for some reason. So one thing you might try is auscultating and doing a POCUS at the same time, because they might be more visual learners, so they're seeing the movement of the heart, they might be seeing the murmur, and that might attune their ear to that point in the cardiac cycle to listen. And so that might help them learn the physical examination as well. So that's a trick that you might try, that some schools are actually implementing. So all in all, this is how we see point-of-care ultrasound in the medical school field and the novel user fitting in with everything else that's being done in the area of cardiac ultrasound. So we see that it might be an emerging competency through medical school, and then you have some level of base skill. You might have that skill and move on, or you might move into a specialty. And then within specialties such as cardiology or anesthesia or emergency medicine, you might develop that skill further, and with a modification and focusing on different aspects relevant to that specialty. So that's how it could all fit together in a spectrum of teaching and learning about cardiac ultrasound. So the thing is that it seems like the way we're headed, cardiac ultrasound or POCUS might be ubiquitous very soon. So what we're going to talk about today is it's important to take a sober look and talk about what can go wrong. And then we also want to talk about how some of us who are working in the Echo Lab can help guide the field, be part of this change in the landscape. So I'm going to talk about a few cases that show some common errors that might occur with cardiac POCUS. So this is case 1. So this was a young woman on the ward who had hyperthyroidism, and the internal medicine the internal medicine MRP heard a murmur and thought it was mitral regurgitation. And so a POCUS was conducted, and sure enough, there was severe mitral regurgitation. So that answered that person's question. There was some concern for heart failure at that time, and so a nice POCUS was obtained. You can see that there might be something going on, something more going on that perhaps a novel user may not pick up on. But the good thing was a regular echocardiogram was ordered in this patient sort of the next day. And so this was the regular echocardiogram that was conducted, and sure enough, we're confirming the mitral regurgitation, but we're seeing that there's something else going on here. And so what our sonographer is doing is following their standard protocol, and in fact, they've picked up some severe tricuspid regurgitation, also explaining some of the findings for this patient. So the point is that with POCUS, you're not necessarily following a full protocol. You're just trying to answer the question. So that's the beauty, but can also be the Achilles heel of this technique, because you might miss some findings which are also important for the patient and to know. And Dr. Leong talked about how POCUS is different from a limited echocardiogram. A limited echocardiogram is a test such that it can be converted to a full echocardiogram. We insist on our sonographers knowing how to do that, so they are able to say, oh, I think this valve is not looking right, let me assess the aortic valve, even though you just wanted to know about LV function, for example. So that's the distinction, which does not necessarily apply to point-of-care ultrasound. So this is an error of omission, and it's also related to anchoring bias. So you're only looking for what you think should be there, and you might inadvertently obviate or delay the need for a full transthoracic echocardiogram. So what's the lesson here? A POCUS scanner should recognize his or her own acquisition limitations. And I think this is important for us to hear, because a lot of these scans are going to come to the echo lab. What we're finding is that this has not reduced the number of referrals to the echo lab. In fact, we're getting more referrals to the echo lab. That's a bit anecdotal, but generally it's important to understand what the thinking is with our scanners and what's being referred to the echo lab. Here's another example of a patient done on the ward, and the patient had some dyspnea. So the physician was wondering about pulmonary embolism and did this point-of-care ultrasound scan. As you can see, the right ventricle is hard to see. It always is, even on echocardiography. The conclusion drawn from here was that there was severe right ventricular enlargement and probably a pulmonary embolism. And so this patient had some downstream testing, but in fact was not found to have any pulmonary embolism. An echocardiogram was conducted, and I think this was done the next day. And in fact, the RV only ended up looking mildly enlarged. So if this echocardiogram had been conducted on the first day, maybe even as an urgent echocardiogram, perhaps we could have saved some downstream testing in that situation. And so you can see the echocardiogram is not showing particularly much abnormality with the right ventricle. So what went wrong with this case? Well, as you know, the assessment of wall motion and chamber size is one of the hardest skills in echocardiography. So it might be out of scope sometimes for some users to really hone in on wall motion abnormality, although in some cases it is quite apparent. RV is very hard to visualize, and sometimes what we do is we even do things like TAPSE, 3D, strain analysis, which we don't have at the point of care at the bedside right now. So the error in this case was that of a false positive, leading to some inadvertent treatment decision making or testing. On the other hand, you can also get false negatives. I don't have an example of that, but you may have seen that where a patient may have had a pulmonary embolism, a large right ventricle that would have been picked up on echocardiography, but it was thought that that was not present based on the point of care ultrasound. So those are some things that can go wrong. And so what we tell our trainees when they are acquiring POCUS skills, the rule we try to hone in is just because you don't see it doesn't mean it's not there. And that has to do with the sensitivity and specificity of this test, which we will talk about later. So the lesson here is a POCUS scanner should recognize limitations of the technology and also the patient difficulty with the patient habitus and scanning. Sometimes maybe a POCUS is not the right way to go and you should just order an echocardiogram. A third example is a nice study done by one of our emergency room colleagues who are very skilled and adept. But in this case, they identified the pericardial effusion appropriately, but had felt that there was no tamponade in this case. And so this is one of those borderline cases where do you call tamponade or not, right? And so an echocardiogram was conducted, the pericardial effusion was there, and you can see very nicely that there is chamber collapse here. And offline analysis was done, and in fact, this patient immediately went to drainage because the blood pressure was sort of borderline. It wasn't really hypertensive. Tamponade is a clinical diagnosis, but the echocardiographer felt that there were enough signs on echocardiography of increased intracardiac chamber size that tamponade could be imminent, and so this patient was treated immediately. So what went wrong here? The issue is that the assessment of tamponade requires extensive ability to correlate structural changes with hemodynamic physiology, ventricular interdependence, and an understanding of that. So we're looking for things like respiratory variation, size, IVC. We're doing a lot of offline analysis and thinking. And again, that's sort of the beauty of POCUS, where you're not doing that, you're answering the question, but it's also the pitfall that can happen because it's not meant for offline thinking and analysis. So for some situations, it may not be appropriate. And so this is an error of false negativity. It could be a life-threatening error. On the other hand, if you have a false positive test, it's not as bad, you just end up repeating the study. So the lesson here is a point-of-care ultrasound interpreter should recognize limitations of diagnosis in the absence of dedicated time for offline analysis. So you can see that there's pitfalls that can occur with image acquisition as well as interpretation. So it's on two ends of the spectrum for reporting. Some of these pitfalls have been well recognized in the literature. So it's important that when we're studying a new modality, we don't necessarily jump on the bandwagon. And so I like to see studies about the limitations. And that does not mean I'm anti-POCUS, but it's interesting to learn about how we can improve quality of this technique. And so one of the things that gets mixed up quite often is this pleural effusion versus pericardial effusion. So that's a common pitfall that can happen as well. So just for the sake of time, there is another study that has been done. There's not a lot of literature looking at pitfalls. There was another study that randomized by Odeja that randomized residents into a group that was a physical examination assessment group and a group that was trained in point-of-care ultrasound. And they were asked to detect findings in patients. Some of them were cardiac and non-cardiac findings. And they found that, in fact, both groups performed similarly well for picking up those findings. But there was a higher false positive rate slightly in the group that was taught to use point-of-care ultrasound. And when they divided those findings between cardiac and non-cardiac findings, it seems like the false positive rates occur more for cardiac findings. So that's why it's relevant for us compared to non-cardiac findings. So we also did a study at our center. This is what we did with our 5 devices. We trained about 12 internal medicine residents And this was sort of a peer-to-peer training regimen by a POCUS champion, an internal medicine resident, Dr. Jeff Wilkinson. And so we divided our trainees into two groups, the peer-to-peer teaching group and one group that learned basically using simulation and e-modules. And they got the amount of training they got was similar to what's been published previously, about 20 to 30 scans over a month. And they focused on picking up LV dysfunction, LVH, regurgitation, abnormal valves, and pericardial effusion. And what we found was that certainly both groups, whether they learned point-of-care ultrasound using traditional peer-to-peer or sonographer-led versus technology, they both improved in their ability to find abnormal findings. That makes sense, right? But what was important was they also had an increased rate of false positives, so type 2 error. And then what was interesting was that they were more confident in being wrong as well, actually. So their confidence level went up as well, which was actually concerning and a bit of a surprise to us. So this is how we assessed them. So these are examples of the diagnosis that our patients had. We asked if they thought it was normal or abnormal, what their diagnosis was. And so when we left it open-ended, that's what allowed them to actually give wrong answers and then their confidence level. So they were able to distinguish normal from abnormal. That improved. Their false positive rate improved, whether they were in the technology group or the didactic teaching group. But their confidence level went up as well with their error rate, which was a little bit concerning. So why is this happening? Could it be because of our training or the kind of training that POCUS is being offered? We don't want to criticize people, but maybe we need to look at the limitation. So what's wrong with this picture? If this is a cardiac POCUS scan, right? So does this patient have dextrocardia maybe? I don't know, but you would probably not be teaching dextrocardia in a weekend course, right? So there's things to think about. And what we found was that a small increase in skill led to a large increase in confidence. We did find that sonographer-led teaching was the best compared to simulation, so that's an interesting note. We found that there was a higher rate of false positives than true positives by the end of the study. And even though we provided a similar amount of scanning. So basically this suggested the critical need for training recommendations and definition of scope in this field. That needs to be done, more work needs to be done in this area. So this slide is good for discussion, and so it really talks about the challenges of POCUS and the field overall. So first of all, there's not a lot of outcome studies done. Does POCUS actually improve patient care? What we're seeing anecdotally is that we're actually getting more studies to the echo lab. So is there actually a cost saving or not? We don't know. That needs to be done. Another thing is workflow. Should all POCUS scans be documented? How should they be documented? Should they be in the physical exam session? Should there be a report? Should every image be archived? How can the servers deal with all this? If a medical student is going to do POCUS, then the resident is going to do POCUS, then the senior medicine, internal medicine resident is going to do POCUS, then the fellow, and then the staff. So are all those images going to be archived? And then who's billing for what? Are all of those studies going to be billed? Are they part of the physical examination or are they a test? If you talk to ICU, they want to bundle POCUS as part of their time for their critical care, whereas Emerge feels that it should be a service that they can bill for. Both make sense, and then I'm not going to referee that argument, but I just want to point out that there are some challenges. Then there's legal implications. There's a couple of cases in the US where the Emerge physician did not conduct POCUS and was held liable, because if it's becoming standard of care, then now do we have to be conducting POCUS? So there's some implications that we need to think about. What is the scope? So, there are specialty needs. Who should be taking care of the specialty needs? And education, what's the duration of education? Who should be teaching this? Is it the echo lab that can play a role? And then, of course, the medical error rate. And then Dr. Leong talked about the attrition rate. It's not like riding a bicycle, where if you've learned it once, you're going to be okay in a year. You actually do lose skills in this field. So what we're doing, this is very brief. There's a poster that you can see. We're providing an e-POCUS service from our Echo Lab. So when someone on the ward wants a POCUS, we go down, a level 3 fellow is going down and providing a bedside interpretation for them and is able to decide if an echo needs to be done. So this is a new model for the Echo Lab to help improve the quality of POCUS being delivered. And this poster is up at this conference if you want to take a look at it later. And the other ways our Echo Lab is providing education. So we now have a journal And then I want to end with this interesting video about what's new out there. Let's see if that plays. Oh, the rainbow death wheel. I have a rainbow death wheel. Okay, let's see. Oh dear, so my video is not playing. Okay. All right, well that was supposed to be an interesting video. But Ultrasound. And so you may have heard a little bit about that from some of the other speakers. And so one thing that might be developing for the Echo Lab is that we have a hub and spoke model where you have multiple users doing scans that may not be necessarily experts, but they're able to call you up and actually live stream the image while they're taking it in real time, guide them. And that is now a real technology that's available. So the point is that I feel that the Echo Lab is going to be playing a very strong role in the area of point of care ultrasound. It's just going to be a very different role in the near future. Thank you.